Party.
Okay, let's see now. Aaron, shall I unmute you? Okay. I can do that. So let's see.
I'm good.
Yeah, it's working.
Okay, Kaylee, I'm gonna unmute. Kaylee, can you unmute yourself? Let's see.
Hi.
Rob, can you unmute yourself? Oh, I don't know if I can unmute you. Can I unmute? Oh, I can. Wow, I got a lot of power here.
You
I'm not
can
used
mute
to it.
everyone too if you wanted.
Oh, okay, I think we got it. So, oh, Rob, you're still on mute. Let's S to unmute. Huh? Ken's iPhone is.
Okay, I'm here.
Okay, all right, now. I want to
Okay.
explain to you, Aaron, we have a front porch kind of format. It's like we all gathered on somebody's front porch. And so it's kind of an easy, we like to keep it an easy breezy group. So don't feel compelled to stay right on your format because
Okay.
there, it's like we invited you with a cup of coffee, maybe spiked with a little bit of rum or something. So, yeah, let's see. Marie and I were, Therese, were you on Monday? Did you hear Aaron's presentation Monday? I've forgotten. I know Prab was there. So we have three of us who heard your presentation on Monday. Not to say it wasn't one we would be happy to hear again, but we have some points we'd like to raise regarding that presentation, which might be helpful to you.
That sounds good.
Okay. And Marie said she really valued the DBS presentation. If you wanted to, focus on that a little bit. The reason being, there are three of us sitting in front of you right now who are about to have DBS, and there is one gentleman, Prab, who's had DBS.
Mhm.
So that is a coming concern. And while you very kindly mentioned that you weren't a physician per se, you have been around you have been around us people, people like us.
Right.
Okay. And the other thing is we are recording this, and there are a couple of people whose backgrounds are the armed services around the Vietnam War.
Mhm.
So they would be very interested in knowing what you know about the project through the veterans hospital there.
Mhm.
Because I know UCSF helps with both centers there, and the UCSF has its own center.
Right.
And Carly Tanner, Susan Heath, and I put on a women's forum at the Veterans Memorial Center, or the Veterans Hospital Center, sorry. And I forgot to ask you about any developments in women and Parkinson's disease, how any of the projects, and why we have why you have a center.
Mhm.
What do you hope to accomplish by having a center at UCSF and the Veterans Center? So, and we have people of varying experience with Parkinson's. Believe it or not, we have some new to Parkinson's in this
Mhm.
group. And we have some who have had Parkinson's for, I guess, Marla, it's between you and
21 years.
how many years?
21.
21
Wow.
years.
Oh,
Okay. And Prab,
Yeah, almost like three decades.
almost 3 decades.
Wow.
And then you had DBS when? How long ago?
2017.
2017. Okay.
Yeah.
So you got an interesting cast of characters here, Aaron.
Sure.
Okay, so this is supposed to be enabled. And anybody else want to jump in with their story? There's Ken, he's a southpaw like I am, and an avid boxer. And then Susan, I'm sorry, I haven't met you yet, but and then there's Kaylee, whose brother also takes boxing. So, we're very, very glad that you're here, and that you don't have to ask permission of your wife and children, because the last time you addressed our group, it was on a Saturday afternoon when families could attend, because it was a caregiver themed talk you gave. He said, I have to clear it first with my family, and they were happily playing somewhere, and they were going to come and pick you up when the talk was over so that you could join them. And that was the only way
Yes.
you could get permission to come to talk to us. So it's a lot easier nowadays, isn't it?
Yes, and in fact, following in those lines, if there is any background noise, it's just my children who don't understand that, you know.
Oh, we'd love to see
I don't know
them.
if anybody heard it, but in the last presentation, my son apparently turned on music really loud and was dancing in the living room. And my wife, of course, stepped outside for like 3 minutes, and she came back to find him just blaring music. And so.
Well, that's good for us. You know,
Yes.
you should
Okay,
have said
good.
to us, okay, time to get up and take a break. Let's
Yeah.
move.
We make children noises occasionally.
Yeah, right.
Yeah. Okay.
Great. Okay, so I will, I'll get started. I think hopefully I can share.
Yeah, you should be able to do that from your end, but if not, there you go.
Right. Right. All right. So I will try and keep this loose and focus a little bit. Just as an introduction for those that didn't attend the first talk this week, my name is Daly. I run the Center of Excellence for the Parkinson'S Center, the Center of Excellence at UCSF, which is sponsored by the Parkinson'S Foundation. A Center of Excellence basically means that we provide a certain level of care, that we see a certain number of patients per year, that we have specialty such as neurosurgery, things like that, that are all in-house so that we can do DBS. We are cleared basically to do any and all therapies related to Parkinson's. We also have to publish a certain number of academic papers every year. And there's a very detailed report that we file with the foundation as a way of continuing our status with them. As was said, but I will say it again, that I am not a physician or a nurse. I don't have a medical background, so there are certain topics that I can't really go into too much detail on, and that I will probably just tell you to speak with your neurologist or to speak with a nurse about, mostly related to medications. I will say that all of the information that I gathered for this talk is readily available. So it isn't things that I am sort of taking from other areas that the common public wouldn't have access to.
Mhm.
And I also want to acknowledge Susan Heath, who's already been mentioned, who is one of our DBS specialists. She's a nurse that worked at the VA for several years and now works actually with us as well. And she's basically just a pro. And so she lent me some slides related to DBS. I just wanted to make sure to acknowledge and thank her. So I won't spend too much time here other than just to say, obviously, Parkinson's is a common disease. Average onset is somewhere around 57, they think. Only about 10% of cases are genetic. I will plug that the Parkinson'S Foundation is sponsoring the PD gene study right now, so that if you're interested in getting free genetic testing, I can certainly help connect you with that. And if you wanted to share my contact information with everybody at the end, anybody who wants to know more about that or is interested in that, you can just email me. It can all be done completely remotely. What they are hoping to do is build a repository of genetic samples. The goal is 500,000, so 500,000 people. And the hope is that with a repository that big of samples, they can start to actually make some new connections as far as what is and what are the maybe genetic bases of Parkinson's, and is there actually more genetic anomalies related to Parkinson's than we know right now, or is this truly sort of an idiopathic thing for the most part? I won't spend too much time on this other than just say that there's been a lot of talk lately about the gut and its relation to Parkinson's. There is a theory that Parkinson's might actually begin as a pathogen, which is taken in at the gut and actually then travels up the vagus nerve. As you will see, the vagus nerve connects to all of these major organs on its way up to the brain. And what we think this might be an interesting hypothesis for explaining how Parkinson's starts is that a lot of people will report, several years before they get any motor symptoms related to PD, that they might have digestive issues, or they might have issues related to constipation, or they might have blood pressure that goes a little odd. And as you can see, all of these things are connected through this vagus nerve as it winds its way up to the medulla oblongata, which is where the substantia nigra is, which is where we find the majority of the dopamine neuron loss in people with Parkinson's.
That is covered for me, so I didn't get a chance to see the whole thing.
Sorry, say again?
Maybe that part of it was covered because of everybody's faces that are on there.
Oh,
Oh.
okay, let me see if I
Is
can.
that
change-
better?
No,
No, you know what? I'll take a picture for you.
okay, that
Hold on.
works.
You can,
Oh,
sorry.
hang on, could you go back for 1 second?
Sure.
That is a beautiful picture, by the way. We won't sell it, we'll just
Can we
borrow it.
move the,
Yeah.
can we remove the faces?
You
Oh,
can
Also thanks
minimize.
to
I can
clinical
make them
exams.
smaller. Let's
Yeah,
see.
you can make it smaller. You can minimize the
Is that
people's
Kaylee?
faces. Yes,
I need
it
to
is.
put you in charge next time, Kate.
No. There, sorry,
Okay,
sorry.
how do-
to,
Is that the
Do I say
little line,
minimize?
hide
Side by
thumbnail
side?
video?
Gallery? What should I do?
well, they have to do it individually on their screen.
I
Oh,
did.
So you did
Did
it?
you get a better
Okay.
view
Yeah.
now?
Thank
Yeah.
you.
Okay, excellent.
welcome.
Thank you, Kaylee.
You're welcome.
Okay, Aaron, sorry, back
Okay.
to you.
You got a picture of that in, right?
Pardon? Yeah, I did.
Good.
Oh, wait a minute. No, I didn't actually, but we have this recorded, so no problems, no worries.
Okay.
Okay.
So just a little bit on COVID and Parkinson's, obviously something that has been a part of our lives for the better part of 2.5 years now. What we have been able to ascertain so far related to Parkinson's disease is there doesn't seem to be any clear risk factors, or that people with Parkinson's are necessarily at an increased risk for COVID. The only thing that they would say is that Parkinson's patients did have longer recovery times. However, Parkinson's patients tend to have longer recovery times regardless. That is just something that happens, especially if they are hospitalized. And patients may have an increased likelihood of infection, obviously, just by nature of, a small group that's contained. And hospitalized, as I said, patients may face basically the same kind of complication issues that they would for being hospitalized for any other thing. One thing that we did find that actually was quite significant was that when COVID restrictions came into play, where spouses or caregivers were not allowed to go into the hospital with the person or speak with the physician when they were being put as an inpatient, patients were having to self-advocate and answer all questions about their health, and that they were effectively on their own to answer all questions related to medications, related to symptoms, related to past medical history. And I think what a lot of people realized is that they relied on their spouses, or they relied on their caregivers a lot to remember all those sorts of things. And then suddenly we're in the position where they were having to answer a lot of this themselves, which caused a lot of anxiety. And obviously then maybe for somebody who was having some cognitive difficulties related to the illness that had gotten them there in the first place, they were having quite a few issues. So hopefully we are past that now, as far as lockdowns, as far as being able to attend a loved one and go into the hospital with them and advocate for them. But something important to remember as far as future hospitalizations might be concerned, that things like writing down all of your current dosages of medications, making sure that you have an ongoing list of any changes in dosages or changes in frequency to medications, all those sorts of things can be very helpful to have on hand.
Aaron, did you mention you do an aware and care presentation?
I do a hospital advocacy presentation, yes, basically related to what are the issues that people with Parkinson's face when they are hospitalized, which I'd be happy to schedule for a later date if people were interested.
Sure, thank you.
That would be great.
Okay. So age, frailty, disease severity, and cognitive impairment were all associated with higher mortalities in COVID. However, that's exactly the same as any other sort of type of hospitalization. So the older you are, the more severe any disease that you have and any cognitive impairment you might have are all going to be associated with a higher mortality. So this wasn't specific to Parkinson's. What was particularly specific to Parkinson's was the pandemic, and the lockdowns really underscored the fact that social isolation and reduced activity is terrible for people with Parkinson's. We are social creatures and we need to stay social, and this is particularly important for people with Parkinson's, which I think hopefully your neurologists have been telling you for a long time, that you need to be out, you need to be active both socially as well as physically. And that if you don't, then the outcomes are going to be worse. And I think that across the board, we really saw that there was more cognitive impairment, there was more depression, there was more anxiety, and there was more cases of dementia that we saw mostly because people just did such a hard stop. It wasn't, I think a lot of patients unfortunately took the opportunity of lockdowns to mean that they didn't have to do anything anymore. And I think that really showed up in a lot of the worst outcomes, both physically as well as mentally with patients, that I think some people with Parkinson's, obviously getting out and being active can be kind of a pain. It can be kind of a chore. And when there was a very good excuse of a global pandemic to offer up as a reason why they weren't continuing to go for a walk every day, they took that. And unfortunately, then we saw a lot of reduced activity and a lot of worse outcomes just related to mobility and as well as increased cognitive impairment. And I think that that alone is really the thing to remember, is that interacting with people keeps your mind sharp. And so things like book clubs, things like walking clubs, things like rock steady boxing, which is basically, exercise along with an ad hoc support group. These are all things that really stimulate our brain in a certain type of way. And that stimulation is really important to keeping your mind sharp. So hopefully you all are continuing and doing more of those things now that we are sort of out from under the thumb of COVID. One other thing, obviously, the expansion of telemedicine, which I think was really good, especially for people who had mobility issues or didn't like driving into San Francisco or driving into the peninsula on a regular basis. Not having to cross a bridge was probably a really great thing if you were seeing your doctor every 6 or 7 weeks. The bad, of course, is that some things were not able to be assessed very well, rigidity and balance in particular. And so I think that a lot of medications probably could have been tweaked, or otherwise, if doctors had had a better opportunity to sort of examine a person or a patient in person. However, I think it worked pretty well for what it needed to. And the hope is now that we're kind of moving back in the right direction. And again, just reminding that, even going to a doctor's appointment does get you out of the house and interacting with the world, which ultimately is beneficial. So I won't spend too much time. Yeah, go ahead.
I was wondering if there's anything noticed about the medication for the COVID, Paxlovid. How did the PD patients do? Was there anything long-term effects or something reported on this matter?
Yeah, I have not heard anything both related to either vaccines or COVID-specific medicines having any sort of increased side effects or interactions with people with Parkinson's. But I also don't know, it might still be too early for them to be publishing those sorts of results as well. But everything that I have heard basically is that, Parkinson's patients didn't tolerate the vaccine any worse than anybody else did. Paxlovid, I'm not as sure on, but it would be an interesting thing to see.
We have a member of our group who's not here, but who reacted almost in a psychological reaction to the booster. And a couple of things come to mind. She's very little, so we don't distinguish dosages at
right, with the vaccines.
Yeah. And she's a woman. So wasn't included in the initial clinical trial, or not that
Mhm.
there was much of one, but so, we just have an anecdotal example of it having a reaction that was different from
Right.
others. So.
Yeah, and I think that, remembering that we all react differently to medications, we also react differently to medications depending on how old we are, that a medication we took regularly when we were 50 suddenly causes a bunch of side effects when we're 70. It's
Mhm.
the exact same medication, it's the exact same dosage, but our bodies become much more attuned to side effects, I think. They become more affected by the same kinds of medicines.
Mhm.
There's unfortunately quite a few Parkinson's patients that can't tolerate taking carbidopa levodopa because it provides things like horrible nightmares or just nausea that never goes away. And really, that's our best medication. And there isn't any real good answers for people who can't tolerate carbidopa levodopa who need it, because that really is kind of like where we're at. As far as medication, as being the gold standard, I guess, for Parkinson's patients. To that end, all of the new medications that I'm going to talk about here are all sort of ancillary medications that help carbidopa levodopa to work better, which I think has been frustrating for some patients. That why are we using the same medication, that was developed 60 years ago, basically. And it's just because this is, it provides a very direct and simple answer to the problem, which is there isn't enough dopamine in the brain. How do we get more dopamine into the brain? And that's basically what we're doing, is a dopamine replacement therapy using carbidopa levodopa. So this first one, Nuriance, came out a few years ago. I think the main benefit with a lot of these drugs that are coming out now is that they are taken once a day as opposed to with each dosage. So for anybody that's on entacapone, which is also called Comtan, that you have to take the pill along with the carbidopa levodopa at every single time that you take your pills. So these now are drugs that can be taken once a day, and they're basically just helping reduce the amount of off time. That is time when your medication is not working and you are having more symptoms of the Parkinson's in the motor fashion. This is another kind of drug that's very similar to Comtan or entacapone. Again, this is a once a day pill, though, as opposed to an at every single time period that you take your pills throughout the day. It's another addition therapy that's hopefully reducing the total amount of off time. And what it does is basically it prevents the levodopa breakdown so that more of it actually gets into your brain and then is allowed to be transferred into dopamine. The levodopa is basically a precursor to dopamine. So then your brain converts it into dopamine. The problem is that taking a pill in your stomach, there's only a certain amount of the drug that's actually going to get up into your brain and provide benefit by virtue of the blood-brain barrier, by virtue of the stomach acids, basically, and things like, hopefully everybody knows that you shouldn't be eating big protein meals, obviously, at the same time that you're taking your medications. Try to be taking your medicine on an empty stomach 30 minutes before you eat or 2 hours after you eat. And trying to save any big protein meals for sort of later in the day if you need to. The last one, Xadago here, was actually approved a few years ago. This is a lot like rasagiline or selegiline, which are two other MAO-B inhibitors. What these do is basically keep the dopamine in the brain for longer. So it inhibits the enzyme in the brain that actually breaks down the dopamine, so the dopamine stays in the brain for longer. Again, this is something that is an add-on therapy looking to lower the amount of off times that a person has. And this one in particular does have some bad interactions with certain types of allergy, nasal congestants, a couple of really heavy duty pain medications. So if anybody is on this one or The other two that I mentioned, selegiline or rasagiline, just making sure to talk to an anesthesiologist if you know that you're going to the hospital, and chances are they will probably suggest that you stop the medication before you have your planned surgery or whatever it is, and then wait a little bit before you restart.
Is this the generic to Azilect?
Yes. Azilect is rasagiline.
Yeah, that's what I take.
And I think a lot of people do, and it can help just to, again, lengthen the amount of time that the carbidopa-levodopa works. And most people don't seem to have an issue with it as far as side effects. What it can do, I think, later on is it can almost work too well, and people can start to have dyskinesias and that sort of thing, which are basically abnormal movements related to carbidopa-levodopa. One that's fairly new is a inhalable form of levodopa. This is called Ambrisia. This came out, I think, about 4 years ago. This is basically what they call a rescue device. So for people that have off times who need, maybe they're having a lot of freezing episodes, something along those lines, the inhalable form of it means that it actually works a lot quicker because it gets into the bloodstream and then into the brain much quicker through the pulmonary tree rather than through the stomach. One problem is that it's these little plastic capsules that have to be loaded into this thing that's sort of a mixture of an inhaler and a kazoo. And it breaks the capsules, which then releases the powder, and then you inhale the powder. It can be very difficult, obviously, for somebody that's in the midst of an off time who needs sort of rescuing to be manipulating these little capsules and making sure that it gets into this thing and it closes properly. So I think that hopefully they are developing maybe a more ergonomic version of this. And the other thing is just that they didn't seem to test this on anybody who had sort of long-standing lung issues as well. So people who have those sorts of things, this might not be a good benefit for them. There is one additional formulation that's actually being reviewed by the FDA right now, which is an under the skin daily infusion of carbidopa-levodopa. And this is basically a lot like the cartridges, if you've ever seen for people who are diabetic. It's basically a little infusion pump that delivers a subcutaneous continual infusion of levodopa into the bloodstream. And it looks to be that it actually, if it is approved, that it might actually provide some real benefit for sort of having a very steady day-long dosage of levodopa in a much more simple way than, some of the other delivery systems that we've seen. And that, the most common side effect really was just sort of skin related to, anytime that you have something on your skin for long periods of time, that basically you're going to have, skin irritation, that kind of stuff. Okay, so we'll move on now to some of the research and treatment therapies for Parkinson's. Hang on, it's getting dark in here. So DBS, which hopefully most of you have at least heard about, is deep brain stimulation. It's basically like providing a pacemaker for the brain. It is done by insertion of these electrodes into the portion of the brain that's providing a lot of these sort of abnormal pulses or abnormal electrical impulses. And you have different settings within the DBS stimulators. The things go in here, and then it's actually attached to a battery pack, which is implanted into your chest. So the wires run behind the ear and down into the battery pack. The battery is rechargeable. I think right now they have developed the battery life to last, they say, somewhere around 15 years. And they used to be something like 18 months when they first came out. So that obviously is a good development. The most common problems with DBS are things basically related to the mechanical aspects of it, so that, leads can break, batteries die out, or they misfire, that sort of thing. But it has certainly been proven to be a safe and effective therapy. It is for people who have had a good response to carbidopa-levodopa, but now maybe are having more side effects and as a result, more off times. What DBS seems to do is provide sort of a hard restart for the effectiveness of your drug regimen. So it is not replacing carbidopa-levodopa, but what it usually does is it allows the medication to be lowered significantly. So for somebody who might be taking 15 pills a day of carbidopa-levodopa, they might be able to drop back down to, say, 5 pills a day, something along those lines, and then slowly titrate up over the next several years while still having the benefit of that medication. So as I said, there's 3 components: the neurostimulator, which is the part that's actually implanted in the brain; the extension, which actually runs down along here behind the ear, as I said, and into the chest. And then, the lead here, the extension, and then the neurostimulators, which are actually implanted here. And this is what holds the software as well as the battery.
Excuse me, Aaron.
Yeah.
So you need, so if you're having your, left and right side, you're going to have 2 things implanted in your chest.
I believe so. Yes.
Oh.
And there are, they do DBS sort of one side as well for people, obviously Parkinson's is a disease that is asymmetrical, so it always affects one side more than the other. So sometimes for DBS surgeries, they will only do the implant on one side, the more affected side, with the idea that if the other side, over the years gets worse, that they have the opportunity to implant another lead. But I think they don't necessarily want to do that unless they absolutely have to.
Mm-hmm.
So as I said, we really don't know why it is that this works, but we know that it does work. And that stimulating basically with this low dose of electrical current seems to disrupt these abnormal firing brain signals. And again, that it, yeah.
I may add a sentence. Is about what Anne mentioned. The batteries can be one battery also. They on the chest, the two batteries with a bilateral replacement for bilateral implantation. Then you have the option to have the wiring for through one battery also. But they would prefer
go to one.
Yeah, but they prefer the 2 battery system because they can independently function and it last longer.
Right.
Yeah.
Yeah. So I think that they're always trying to mitigate risk, and it's it's trying to weigh, okay, well, you have one battery, it's going to be good for now, but then we're going to have to go back in and replace that 3 years earlier than we might have to if they were separated. So I think that, and as well, if you have 2 stimulators, if one of them malfunctions, you still have the benefit of the other one. Whereas if you have a single stimulator and it malfunctions, then you got bigger problems. So as I said, the hope is that it really just increases the responsiveness of the medication that you're taking. And that hopefully it reduces that as well. And by reducing the medication, you're also reducing any side effects that the person might be experiencing, like dyskinesias or wearing off effects. So who are the ideal candidates for somebody for DBS? They want someone who's had Parkinson's for at least 5 years, that they show a definite improvement their motor symptoms with dopaminergic therapy. So basically that there is a noticeable difference between a person who has not had their medication for the day and then when they take their medication and it's working well. That this is somebody who the symptoms are no longer well managed with the medication alone. Freezing of gait and postural instability should not be the primary symptoms. And the reason for that is that most likely, that this is a form of Parkinson's that's not responding well to the medication in the first place. So deep brain stimulation was actually developed first for people with essential tremor, which is sort of a different kind of motor disease. Catherine Hepburn, if anybody remembers Catherine Hepburn, she had essential tremor and she actually had it very badly. So she had the head wiggle and her voice was really shaky and her hands shook. So this therapy was actually developed for people with essential tremor. And then they realized that it actually was also very beneficial to people with Parkinson's. You need to be near a place that does DBS surgeries a lot because adjustments can be often. They have what they basically have these group settings. And so they are programming the stimulator to see, if we do it where it fires this many times on this particular electrode and this many times on this particular electrode, does that work? Is that better? Is that worse? So there's a lot of fine tuning that can go on to it. And some of that needs to really be done in person. It can't always be something that you just sort of talk over the phone or done by telemedicine. So not living 5 hours away from a place, that you have to go to often is going to be ideal. And I think also just having reasonable expectations that this is not, something that's going to make the Parkinson's go away. That this is basically another adjunct therapy that's hopefully going to make the medications work much better and hopefully extend the usefulness of the medication regimens for much longer. Anyone with severe psychiatric disease, dementia is not going to be a good candidate. And in fact, people who have cognitive difficulties of a certain point, basically DBS surgery is going to make it worse. So there is a whole very robust neuropsychological evaluation that goes in for anybody who's being considered for DBS surgery, because they obviously don't want to operate on somebody who is ultimately going to do worse once they've implanted stimulators. So what are the risks? About 1 in 200, there's a danger of a stroke. This basically is because they are passing a very fine wire through the brain. And as much as they try to avoid hitting any sort of blood vessels, it's not 100% guarantee. But that is why they do all these MRIs and imaging beforehand as well, and they map the trajectories. So the hope is that anything that does happen, that it will be minor. But it is, a risk, and it is brain surgery. I think that's an important thing to remember too. It was interesting. We used to have patients that would come in and they would be getting their second opinion. They'd never really been locked into a diagnosis of Parkinson's, and we would, diagnose them and we'd say that they did, and they'd say, great, I want to get that DBS surgery. And, it was like, whoa, you're in a real rush to get brain surgery. Not to mention that you haven't even started medication yet. Like, let's slow things down. But I think, we live in a society where if there's a surgery where you can cut it out and get rid of it, like that's what people want to do. And unfortunately, that is not what DBS is. DBS is a very successful surgery for people of a certain group. Risk of infection, which I think with any surgery is basically, going to be a risk. Primarily, it's going to be actually here rather than here. That there is a risk of sort of a post-op confusion or delirium that hopefully is transitory and does, go away. But, that's certainly a possibility, especially for people that have had general anesthetic, which obviously we all are much more affected by the older we get as well. There may be a slight decrease in the verbal fluency and working memory. Again, this is something that may be transitory, but also is something just to remember. And that certain symptoms, can be made worse, such as speech, mood, and executive function. Executive function is basically a portion that is already affected by Parkinson's. That's our ability to multitask, to make high-level decisions, weighing different, thoughts, that kind of thing. And for people with Parkinson's, that just gets a little more difficult.
Aaron, could you
Yeah.
Could you give an example of what may decrease verbal fluency?
Mhm.
What does that, can you describe what that would look like?
Yeah. So that's basically, what's interesting is a lot of these sorts of things are things that people with Parkinson's already have difficulty with. And so I think there's sort of a chicken and the egg thing at play here. Verbal fluency is, people who have problems with verbal fluency, it's sort of the tip of the tongue phenomenon, of having that word and you know what word it is, but you can't quite come up with the word. Or asking people to name 20 things that they would buy in the grocery store, and they name the first 6 of them really quickly, and then there's sort of a brain lock, and you suddenly just have trouble getting that next one out. So I think that's probably the best example of verbal fluency, is just that it may be a little more difficult to express yourself and maybe as fluently as you want to. It is not that you necessarily suddenly have the inability to speak or to speak intelligently, but there just may be a little bit more hesitation before you come up with the word. And again, these are all sorts of possibilities. These are not things that are very common.
They're not certainties.
Absolutely not. I mean, hopefully what we all know about Parkinson's is that there are no certainties whatsoever, that everybody's Parkinson's is so unique, that everyone has one particular, symptom that seems to be worse for them, but that's absolutely different in the next person that you meet with Parkinson's. And I think that's one of the dangers of sometimes talking to people and you say, oh, well, I have Parkinson's, and they, for whatever reason, can't wait to tell you, about their uncle who had it, or their next door neighbor who had it. And it's either the best case scenario or the worst case scenario, I've noticed, where it's like, oh, my aunt had it, and, she lived to be 98 and she just had a tremor. And then somebody else says, oh, my next door neighbor had it, and he was using a cane a year after he got diagnosed. And it's like, you don't need to share those sorts of things. But I think it's just, you can't make comparisons with Parkinson's. It really is a very unique disease to the person. And so again, you can't make a lot of predictions as far as how people are going to respond to different therapies either. I think that's been one of the most disappointing things, again, for people maybe who don't respond well to carbidopa levodopa, is because we see how well it does work in some people, and the hope is really that it would help everybody, but certain people just cannot tolerate it. And that can be very frustrating.
Thank you.
So this is just a better example of where the DBS leads are implanted. So there are 2 places that they are planted, either the global pallidus or the subthalamic nucleus, but it usually is one of these 2 areas. And then the impulses basically, affect all of this area. There are 2 ways of getting the surgery. You can do it while you are sort of awake, or you can do it while you are asleep. One of the benefits of doing it while you're awake is that they can actually test you in the midst of the surgery to see how effective the surgery is. So they do all of the standard things that a neurologist is going to do on just sort of a standard clinical exam, but they can do it sort of in real time before they actually sew up the head, as a way of seeing, has there actually been a benefit already of the implant. And then there is the sleep surgery, which obviously is just done under a general anesthetic, and that they do this basically in a MRI guided machine. If you are awake, this is the frame that they put onto you, and then they load basically a gigantic machine that threads the wire into your brain. The neurosurgeon basically, guides the wire into the machine, and then the machine sort of is in charge of getting it into the brain. Mostly this is due to the fact that machines can do minute changes much more than a human can. Then so this is the machine I'm speaking of, and this is basically the head frame. And then MRIs that they use beforehand, they basically plan the trajectory and where they want to get the lead to, while avoiding all of the blood vessels that may be in the area, obviously. So this is a patient actually doing the motor testing. This is Dr. Larson, who unfortunately moved to Arizona and is now running several huge groups down there. But I had the honor of working with him actually on a couple of studies. And in the sleep in the MRI suite, they do watch and they do an MRI and then they go back in and then they do an MRI. And so they're able to actually watch the lead go into the brain. What they don't do is implant the generator and the stimulator at the same time. What they will do is basically put everything in and then they will actually do an outpatient surgery in a little bit later to actually do the stimulator. And I think the reason that they do that is because of the dangers of the MRI, that they don't want to damage the stimulator while they're implanting it. I think you're muted if you're asking me a question.
Is the stimulator the device that goes in your chest, Aaron?
Correct. Yeah.
Okay.
Yeah.
Thank you. And that's done in outpatient? Are you knocked out?
Yeah. Yeah. It's pretty amazing. I've been able to watch actually both the awake surgery and the asleep surgery. And the thing I'm always struck by is, the implantation is just as it seems like it would be, where they just sort of like make an incision and tuck this thing into you and plug it in and sew you up, sort of like they create just a pocket for a second and then they sew it up.
Oh my gosh. But you have to be asleep for that one, huh?
As an outpatient, I don't know that you would, but
okay.
it's
Well, that's
possible that
fine.
it might be something that they do. And actually, I didn't see the second part. I only saw the implantation of the asleep surgery.
Actually, you're partly awake, and then they keep asking questions, but to make sure that you're conscious, and they keep asking your name, what do? You don't know where we are.
Mhm.
Or
Twilight.
Yeah.
How long is the surgery?
So
Which one?
The first one.
The first one. I think it's about 2 to 3 hours usually. It depends. I actually witnessed a couple of surgeries, and the first one took forever, but it wasn't anything to do with the surgery itself. It was machine stuff that basically they were having to make sure was all working properly. So that's the kind of stuff that can slow things down, I think. And obviously you want everything to be working perfectly before you really start with the implantation. So clinical research is obviously a real vital part of Parkinson's. Clinicaltrials.gov is the best place to find out about current research studies. The search that I did last week basically showed there was about 250 recruiting studies in the US right now. The majority of those are actually observational or non-interventional studies. So these are things like PPMI, Fox Insight. These are studies that are basically trying to collect more information about, where people are coming from, how long their disease has had, what symptoms seem to be primary, and trying to then collect as much as you can so that you can start looking at, certain groupings. Dr. Tanner, who you mentioned, is an epidemiologist in addition to a neurologist. So obviously those sorts of studies are really in her wheelhouse. And then there are, phase 1, phase 2, and phase 3 drug studies for the most part. A phase 1 is basically, is this safe? Is this something that is tolerated? If so, usually you move on to phase 2, which tends to be a double-blind sort of placebo-controlled study. Again, looking at safety, but also looking at different dosages, maybe if it's a new drug. So trying maybe a low dose, a higher dose, and then a placebo. And then phase 3 studies is really right before, you're going to apply to the FDA. At that point, you have one dosage that you've pretty much decided is going to be the most beneficial versus a placebo kind of sugar pill. And And then you look for, is there any significant differences in symptoms? Phase 4 studies are for drugs that basically have already been approved by the FDA, but that they are now looking to see if there are other ways that they can be useful, or if they have made certain changes to the drug, how those might affect the overall effectiveness of drugs. I'll talk for just a second about stem cells, or actually I'll stop for a second to see if people have questions, since we're a front porch here.
Yes, we are front porch. If there are no questions at this time, I want to ask one about DBS. Does one have to have all the hair removed on top of your head? Do you know, Aaron?
I think, I know you have to, I mean, you have to shave your head. I don't
Like
know if you
gentlemen
have
in
to
the
shave all
picture.
of your head.
Okay, I'm
You
going to
can
hang
s-
on to my hair for as
you-
long as I can
You
then.
can see my hair.
Just as
true.
long as it grows back, that's
Right.
Yeah, some parts didn't grow.
You don't strike me as giving me a lot of confidence, Prob.
But you will come to an agreement that the hair is not important.
Okay, that you can say that, but do you believe it?
Yeah.
Thank you,
If
Aaron.
if I may add a comment about what you, verbal fluency. That's
Verbal
something,
fluency?
verbal fluency you asked.
Mhm.
Yes.
So the traditional description of PD textbook material is progressive neurodegenerative disease. So this verbal fluency can be coming in even without the PD surgery. So
Okay.
it could be due to the after effects of the surgery. Because I have the problem. I sometimes start talking and then I forget the words.
Mhm.
You know, then something very familiar. You know, hardly have any experience like that. And the fluency in talking also. Sometimes I would like to talk about 3 things. What are the 3 things?
Yeah.
You will say 2 things and then the third one you forget.
Mm.
So like that, you know, the verbal fluency could be due to the progression itself.
Okay,
Right.
thanks, Prob.
Okay, so stem cells, we've been hearing about stem cells for a long time, and it seemed like they never really went anywhere. And they now seems to be a sort of rebirth of the use of stem cells. The technology, I think, has caught up a little bit. So the 2 types of stem cells that most likely are going to be used for people with Parkinson's are going to be either the embryonic stem cells, or induced pluripotential stem cells, which are basically genetically modified cells. And there are 2 big studies going on right now. There is the Blue Rock study, where they are using the embryonic cells and trying to basically transplant them into dopamine making. So basically trying to create new neurons in the putamen. This is the enrollment was just finished. So this is going to be ongoing for the next several years, basically tracking how these people are doing. This is a phase 1, so it's probably not many people. And again, you know, everybody does get the treatment in a phase 1, so there is no control, but you're also looking for safety more than anything. So you want to make sure that you know, are not damaging or harming people. There's another phase 1 trial that's getting ramped up right now by Aspen. This one is using actually a skin sample from the patients themselves. So as opposed to an embryonic stem cell, which is coming from, you know, some sort of other source, this one is actually getting the skin cells from the patient themselves. And why that is important is that there does tend to be some issues related to, you know, the immune system when you have an implantation of something like an embryonic stem cell, where the body basically sees it as a foreign invader and may start to attack it. You don't have that problem if you are using a skin sample and growing the cells from the person themselves and then implanting them back into their brain. So that's a pretty exciting development And again, this is using the pluripotential cells that are basically being genetically modified from already mature cells rather than an embryonic cell, which is not yet developed. Another very exciting aspect of new treatments is gene therapy. This is a study that actually I am involved in right now, related to GDNF, which is this glial-derived neurotropic factor, which is basically like a supportive growth factor in the brain, which hopefully serves to protect neurons. The way that this is actually delivered is by means of a sort of a mute virus. The way it's described is that the virus is basically like an empty envelope, and you put in the gene factor for this GDNF, and then that virus delivers it into the brain, where it can then be replicated through the viral process. This again is also looking to target a specific area of the putamen, which is where we are seeing this dopaminergic loss in people with Parkinson's. And the hope is to actually target and cover as much of the putamen as we can, with the hope that then this neurotropic growth factor, this protective factor, will try and cover and hopefully protect as much of that area of the brain as possible. So this again is ongoing as well. So there are a couple of other studies related to GDNF. One where people were actually given it only on one side, and that just finished up. Another one where people were given it on both sides. And then there's actually another study that they are currently enrolling for, which is very similar to this phase 1B, but this time they're actually doing it for people who have MSA. MSA is multiple system atrophy. It's an atypical Parkinsonism. And it has a lot of the same characteristics as Parkinson's disease, but it also has additional problems related mostly to the autonomic nervous system. So this is things like heart rate. So people with MSA, when they stand up, basically their blood pressure drops and they can faint. They have a lot more issues related to digestion, urinary problems, constipation, even more so than people with Parkinson's. MSA, the prognosis is obviously not as good for people with Parkinson's. So it's very important, I think, that they are actually running a study where they are hoping to actually see what sort of benefits might be had from this same type of gene therapy. One other thing, which actually was just approved very recently, is focused ultrasound. This is thought to be, one of the newer treatments based on a very old treatment. It's creating basically and damaging a small portion of the brain with the thought that this actually is going to treat primarily the tremors related to Parkinson's. There are people with Parkinson's where tremor is the primary symptom, known as tremor dominant Parkinson's, and that you can actually alleviate a lot of that by making a very small lesion in a portion of the brain. Why this could be very attractive to some people, obviously, is because it is minimally invasive, incision-free. The thought basically being that, that there is no risk of infection. It's using sound waves, and the sound waves basically only damage when they are converged in a very specific area. So I'll show you a picture in a second of what it looks like. It is important to remember that much like DBS, this is not a cure for the disease. This is only a treatment for the symptoms of the disease. So this is essentially what is happening, is that these sound waves are coming from all different directions, but they're only being focused in one very small section, and that's the only area that's actually being affected. So you have this gigantic helmet-looking thing on. You have to be in an MRI for several hours, and then you have this focused ultrasound and these sound waves that actually all target into a very specific portion of the brain. And as it says, only where they converge is the temperature high enough actually that it creates this lesion. What are the advantages? It's obviously it's an immediate and durable improvement of the tremor, and that it can be done in one day as an outpatient and low or no risk of infection. The one downside is that it's not adjustable like DBS would be. Once you have created brain damage, you can't take back brain damage is basically what it comes down to. And that it's possible that the tremor may progress even after you have done this particular surgery, and that there isn't much you can do about that. Whereas with DBS, things can be altered, things can be changed. As I said, settings can be done, groupings, that sort of thing. Whereas with something like this, it's done, and whatever the benefits are, what the benefits are. Candidates have to be okay with the fact that it can only be done on one side. So that's another difference with DBS, is that it actually can't be done both sides, but only one side. You can't be claustrophobic because you have to be in that scanner for about 3 hours. You have to shave all your hair, basically down to the scalp. You have to be alert and cooperative. There is a very painful, I understand, about 10 seconds of that final tissue area, and that you have to be sort of awake for that. And much like any other surgery, you have to be off of all anticoagulants. So I will stop sharing and just open it up. You can ask questions about the talk. You can ask questions about Parkinson's. I'm sort of up for anything.
Thank you, Aaron. That was
You're welcome.
wonderful. Okay. All right. Let's go. Let's go, folks. Anybody have any? Donna, you got a question?
Well, mine doesn't apply, I don't think, to DBS, but
No,
That's
anything.
okay.
mobility. I have the balance issue with the lagging gait, and I was listening to another Parkinson'S seminar this afternoon, and apparently I've got the worst kind of issue from the standpoint of balance. Can you elaborate or give an overview of any of that?
I mean, balance problems are difficult because they don't respond to medication, unfortunately. The best thing that you can do is physical therapy to try and make sure that your muscles remain supple. That, you know, the great thing about balance practice, things like yoga, Tai Chi, are really beneficial, and that you actually do see a noticeable and significant improvement. And it's more, I think, about learning when you lose your balance, being able to either catch yourself, or if you're going to fall in a way that you're not going to injure yourself. And I think that, you know, for a lot of people, unfortunately, it's not a matter of if, it's a matter of when they're going to have a fall, but it's, you know, is this a fall that you can get up from right away, or is this a fall that's going to, you know, break a bone, that kind of thing. And that's obviously what you're trying to avoid.
Right.
The great news is that people with Parkinson's are basically able to get continual physical therapy, because the goal when in any referral to physical therapy is to maintain a certain level of mobility and quality of life. And so if that can be shown, basically things like, you know, Medicare will continue to pay for physical therapy ongoing if you and your neurologist basically can show that it is important for maintaining your independence. If they ever do push back, you can just transfer and get occupational therapy for a little while and then go back and get physical therapy some more.
Mhm. Thank you. Thank you very much.
I have a question.
Oh, go ahead, Marie.
On the news, there's a new medicine for Alzheimer's,
Mhm.
and apparently this medicine dissolves plaque in the brain. Is that something that the PD patients could use?
That drug in particular, no, but there are other drugs that are being developed right now in research that are doing the same thing, that they are inhibiting basically the clumping of these proteins in the brain. And so we are trying to develop things that are targeting those, with the hopes that if you reduce the amount of protein, that you hopefully will reduce the progression.
Okay.
Could you talk a little bit about what the two centers are doing for veterans, how they could be
Yeah.
involved, or
So the San Francisco VA and a lot of other VAs have what they call PADRECs, which are centers that are specifically set up for people with Parkinson's disease. PADREC is a very long acronym. They love their acronyms in the military, but it's basically a Parkinson's disease research and educational center, something like that. But it's just a place where you have doctors and nurses who are trained in movement disorders. Veterans do seem to have an increased risk of Parkinson's, mostly related to exposure. I know that Vietnam veterans recently, got service connection for Parkinson's for people that were exposed to things like Agent Orange. There are herbicides and pesticides that have been proven to be damaging to the areas of the brain that we know Parkinson's shows up in. So I think that, they can be service connected now and actually get benefits for things like Parkinson's. But really, the PADREC is just another version of the clinic that you probably go to normally, but it's just set up for veterans because veterans get their health care at the VA. And again, all of the UCSF doctors, for the most part, also train at the VA. They do shifts at the VA. So they are definitely, if you go to the San Francisco VA, chances are you're seeing a physician who also works at UCSF.
I have several questions. Can you hear me?
Yep.
Okay, great. Awesome.
Is that Susan?
So,
Yeah.
yes.
Susan, okay.
So, my grandmother has Parkinson. My mother has Parkinson. I have essential tremor. My worry is that my essential tremor will cross over to become Parkinson, essential and Parkinson. So you mentioned about the genetic testing.
Yeah.
So is this genetic testing that you're talking about will be for somebody like me, and will it be free?
So for right now, it is only open to people who have a diagnosis of Parkinson's disease. I think that based on your familial history, I can see why you would be interested in getting genetic testing. And as far as essential tremor versus Parkinson's disease, I think it's really split in the community as to whether there is a true association or an increased risk of people with essential tremor developing Parkinson's. Part of the issue is that there are people with essential tremor who have components of Parkinson's disease. And so there's this sort of mix of the ET and the PD. And it's difficult, obviously, to parse that out. There's a particular scan called the Dat Scan, which was actually developed for that very reason, to be able to look at people's brains and decide based on this scan whether they actually had essential tremor or Parkinson's disease, because clinically it was really difficult to tell for the neurologist. What they will see is in a scan of a person with essential tremor, they will see a very different shape of the putamen area of the brain, as opposed to someone with Parkinson's, where basically what you see is a deficit. It's sort of looks like two big lima beans is what it comes down to. And that's the shape of a person whose brain function is essentially, normal and doesn't have Parkinson's. Someone with Parkinson's, one side will be more affected than the other, and it'll start to look sort of like a comma rather than a lima bean. And it's basically, you are seeing the deficit where the neurons are not working anymore. The tracer that they use binds itself to these neurons, and it won't bind anything that's not working anymore. And in that way, they can actually see the dysfunction in the brain. So as much as I would love to have you be a part of the genetics testing study, unfortunately, if you don't have a diagnosis of Parkinson's, that wouldn't be something you'd be eligible for. But it certainly sounds like you would have reason to seek out genetic testing.
Yes. So what was the testing that you say that would distinguish between essential tremor and the Parkinson?
It's
The-
called a
the
DAT scan, DAT scan.
Okay. And is that an MRI?
It's a CAT scan or a PET scan. So it's like a fancy MRI, basically.
Okay.
Is that in-
So is that scan beside that? Are there any type of blood tests that can tell you whether, or any type of gene testing that can tell you that there's a possibility? How do they distinguish? How do they know that if a person has Parkinson beside the brain scan? Could it be something that's missing that you can detect blood?
So Parkinson's is still a clinical diagnosis, which means that there isn't a blood test that can tell you whether somebody has Parkinson's or not. It's something that a neurologist will evaluate based on your motor symptoms, based on your history, and come up with a diagnosis. And they always say that it's probable Parkinson's disease, basically as a way of saying that, no one really knows for sure. The only way you can be for sure is to perform an autopsy and look at the brain, but obviously that's not what you're looking for. If the genetic testing will show that you may be a carrier of a Parkinson's gene, but being a carrier doesn't necessarily mean that you have Parkinson's either. You can carry the gene and not develop symptoms. You can also obviously have symptoms and not have any sort of genetic basis for Parkinson's. So there is no sort of blood test or litmus test, unfortunately, for Parkinson's, that it is still a clinical evaluation. The DAT scan can help at times when maybe you are somebody who has essential tremor, but has some Parkinsonian symptoms along with that.
So I have two more other questions, if I may ask. The other thing was that I noticed that you said that this was done by a nurse. Her name is Susan Hepburn. Heath, sorry, Susan Heath. I was wondering that if she is there any way to invite her to have a future talk regarding about medication and management? Would you be open to ask her?
I mean, if you guys are interested in having a medical professional give a talk, I can probably explore that. If you have something.
I'm a little unclear, Susan. Was the medication for yourself or for your mother or your grandmother?
I actually would like to have the nurse to come in so that we could talk more about medications and any management for Parkinson as well.
Parkinson's, as it pertains to your family members?
Right.
Who's that for? Oh, okay.
I mean, I would suggest maybe just making an appointment to see the neurologist, rather than have it be in a group forum.
Well, the problem I have is that, so when my grandmother was diagnosed with Parkinson, it was really unclear to us how to manage it. Then when my mother got it, we didn't know that she actually had Parkinson, and we suspected it, and we were pushing for her to be diagnosed. And then when she was diagnosed, it was kind of at the late stage already. And it was like, so there was a lot of mismanagement in that she suffered, we suffered. And I wanted to learn more about it because right now she is in the nursing home and she is having a very hard time with it. So with all this new medication coming in, I actually would like to, see if we can talk to the nurse and find out, how these medications are being, how to manage it, to have a little more insight. Because when I was talking to my neurologist regarding about me having the potential of Parkinson, the doctor kind of brushed it off and said, you know what, I don't think it's that serious. So I don't, after having gone through all the trauma with my grandmother, my mother, and myself, I don't want to find things when it's too late. I want to know when it's in the beginning or how to manage it better, for my mother's sake and for myself, because the potential of me having Parkinson is also very high.
Hello?
So that's why I wanted to see, if there's a way to, if she's open to come in and talk to us, if there's something that we all can learn that is for ourselves, for our families, and also the potential of us, for people who has Parkinson, who have children, who also could be going through the same thing.
Susan? Your family experience with PD, it seems to be through the female side of the family, right? You don't have any brothers or uncles or,
Actually, I don't know,
Oh,
because
okay.
I actually saw symptoms from my uncle's side,
Mhm.
from my from my brother, and even my father as well. So that's why I couldn't tell if, because these two combination, my Parkinson from my mother or essential tremor from my father, and that became a little combination. So it's very hard to tell, because I saw the tremor. I
Mhm.
saw also the cognitive decline. I
Mhm.
also saw the different symptoms, the things that my grandmother was later on, when after she died, then when they were talking about how she was, and then with my mother, and I was thinking, why is it that the PD patients were not, say, for example, if you have a family history of PD, why wouldn't the doctor be paying attention and say, you know what, we need to also check you out?
Okay, Susan,
Yes.
let's take this a little bit, step back a little bit. Rather than calling Susan Heath out to a situation that she would not be familiar with, and you are the translator of what she says into what you think should be done for your parents, I think it's better for you to begin with a physician, a movement specialist, different from the one you have, so that you can, and someone willing to address the concern you have, that there may be a familial connection. That can be done. That can be done ahead of time through conversation with the doctor's office or with the project. The thing about the Bay Area, and this is why we're so, to have Aaron come and talk to us at this time, just to us, is such a luxury. We have an embarrassment of riches in our area. We really do, because we live in the Bay Area. There's UCSF, there's Stanford, there's I'm missing somebody somewhere.
Kaiser.
And there's Kaiser. That's
Kaiser.
how can I miss my dear old Kaiser? Oh my God. And then we have different, we have 23andMe, we have Stanford's program, aging. There's an abundance of places. One has to just kind of take a deep breath and do some information finding. And if you like, you can give me your email address, and I will send you some places you might begin to look, because your concern about your parents are both the genetic side and the medication, and they're two different issues. There are movement specialists who are known to be, great technicians with the pharmaceutical side. And there are also places where you can investigate the concern that you have about your heredity, but one cannot get that from asking a very good-hearted and willing nurse to address everything. Okay, does that make sense?
Yeah, I was just trying to find some information, because
Yeah,
I didn't
no,
know where
okay.
else to go.
Yeah, no, I think we can do it, but it's not a one-stop shop.
Yeah.
You're gonna have to, but I
So
think
that-
you have to get very focused in
Mhm.
your questioning, okay?
Yeah.
And I'd
Can
be
I-
happy to help if you want. So just get in touch with me.
Can I ask you a question?
Yes,
Hello?
Yeah.
yes.
Yeah.
yes,
Before I
there's-
forget, I'd like to
Oh,
thank you.
but we have to watch our time. Aaron isn't
Right.
here forever, he's
What a
got
wonderful talk.
to put
I do want to
he's
have
got-
dinner at some point. I have to say.
Oh, I'm sorry. Dinner is being
Very
held
great
up.
to talk.
Oh, Lord.
Very
Okay.
informative talk.
You're so generous.
Thank
Thank
you. Thank you so much.
Yeah, thank you.
Now that I've gone through this GBS, I was wondering, I was generally thinking about what happens to the patients after down the line, for 10 years from now or 15 years. Is there any information on that?
Mm.
like when it comes to when it comes to replacing the battery, it becomes an ethical question whether to go for it or whether the benefit of changing the battery is better than leaving the patient as it is. At a later stage, 20 years or something, when the patient is in the 90s, for example, if somebody is there. So what happens? What happens to these probes? Do they stop functioning or?
Yeah, I mean, I think that, entropy is unfortunately something that we all have to deal with in our lives, and the fact that the leads do fail at some point, or they become brittle, or the stimulators themselves, become problematic, and the batteries don't recharge as well as they used to, and they do have to be replaced. So a lot of the issues, with DBS, are hardware related. It's also the fact that somebody, if they fell, could actually damage the lead somehow, just by virtue of a mechanical fall. So there are these things that exist. I think that what is exciting is that you have there are new developments with the stimulator packs, the battery stimulators themselves, where they're actually developing new software that can work with the existing leads, but may actually be more sensitive, or be able to fire in more minute ways that actually you're able to tweak much more fine-tune the response. So I think that there are a lot of things right now where they basically have a bunch of people who got DBS in the last 5 years, who the anticipation is that probably in the next 7 to 10 years are going to need a replacement, and they're being registered in so that they know exactly, what they have had implanted and how best they can replace it with the most up-to-date and maybe even the most responsive new type of stimulator. So it's great because it's kind of like you have the existing, lines that can stay there, but then you can basically attach a brand new, for lack of a better word, a brand new computer to it that then allows it to function in a much more responsive way.
Is there anybody who has a question before I pop the very last one to Aaron? So Aaron, in a sense, are you saying those of us who are about to have DBS or will be having DBS in not too short a time, it might be a good question to ask, how can what you're doing today most or best access the technologies we are anticipating, as you say?
Yeah, I will do you one better and ask, are there any research studies related to DBS that are happening right now that I might be a good candidate for? Because, some of them might just be as simple as a registry so that, they're sort of marked in time. But they also, I think, as I said, are developing a lot of new lines of stimulators, and that it could be, something really interesting if you're open to it. I think for DBS research trials, it really probably isn't all that much extra effort because there's so much tweaking and back and forth that has to happen at the beginning of DBS surgery anyways, that you really are just sort of like, okay, well, I met with the neurologist and then for 15 minutes, we talked about the research study, but it's not really any additional, time problem.
We could also go on the website that you.
Right.
That would be great. Oh my, Aaron, you gave above and beyond. Oh my gosh. You deserve extra dessert tonight.
Oh, good.
Thank you so much.
Thank
We
you. It was a
appreciate
pleasure
it.
to see you all. And please email me if you're interested in the PD gene study. And also if you want me to come back at some point, come up with some other topics that you want to know more about, and I'm happy to create something for you. Okay.
We love it. Oh
Thank
my
you.
gosh.
Thank
Thank
you.
you so
Great.
much.
Thank you.
Everybody
Great
be
to see you
well.
all.
They will.
Take
Thank
care.
you.
Thank you.
Aaron. Good
you.
night.
Thank you.